This week on the BackTable podcast.
I think as much information as we have, as much literature is out there, we really don't know how much cement do we really need and in what patient. We know if you get kind of a blocky, chopped, squared off, dense bone, you tend to have an adjacent increasing fracture. If you kind of get that spongy, kind of described, flow in vertebroplasty pattern, they tend not to be as stiff and sore. And then I think it's a matter of what do we do? So for me, the reduction has been better with the Kyphon assist. And the good point is I can get that flow into the other parts of the vertebrae as a vertebroplasty by rotating my Kyphon assist or scoop cannula, is how I call it, to get the other areas. So I can control the flow into the vertebrae.
Welcome to the BackTable podcast, your source for all things endovascular or otherwise minimally invasive. You can find all previous episodes of the podcast on iTunes, Spotify, or backtable.com. Subscribe to the podcast, leave us a review, or reach out to us on Twitter or email to let us know how we can make this a more valuable resource for the endovascular community. Today's episode is sponsored by Kyphon by Medtronic. Kyphon balloon kyphoplasty has been well reported in the literature over its 20-plus year clinical history, treating more than 1.6 million vertebral compression fractures worldwide, including comparing bilateral to unilateral procedures. Bilateral kyphoplasty has been shown to offer improvements in vertebral body height restoration over unilateral kyphoplasty, and Kyphon balloon kyphoplasty has demonstrated in large randomized control trials to give patients pain relief, better function, and improved quality of life versus non-surgical management measures. Visit medtronic.com/kyphoplasty to learn more. This is Michael Barraza returning as your host. I'm thrilled to be joined by Dr. Tom Andreshak, an orthopedic spine surgeon with Consulting Orthopedic Associates in Toledo, Ohio. Today, we're going to be talking about vertebral augmentation, particularly performing vertebral augmentation from either Unipedicular or Bipedicular access. Dr. Andreshak, thank you for joining us today.
Thanks for having me.
You're in Toledo, right?
Yes, I am. Metro Toledo area.
How's the weather there today?
It's actually bright and sunny, but chilly.
Not working?
Not today.
Good. So you're actually the second spine surgeon in a row that I've had on the podcast, which is kind of unusual. Last episode I hosted was with a spine surgeon talking about radiofrequency ablation for spine metastases, and that was a neurosurgeon, which we all know is not as good. So, I'm glad to have the better type of spine surgeon on with me today. So thank you for sharing your time and superior expertise.
Oh, not a problem. We all have to learn to play in the sandbox together. We all do the same thing. So we all have a little bit different things to add.
That's right. And, that's kind of one of our things at BackTable. We're about collaboration rather than competition. And we really value having physicians of different specialties, than us. We're mostly interventional radiologists here. I think we really gain a lot from getting perspective from different specialties. And we really appreciate having yours on here. So, Tom, if you don't mind, tell me what your practice is like, what you do, what your group is like, and what type of hospital or outpatient setting, where do you work?
So I am in the Toledo metro area. I work at a major level 1 trauma center called St. Vincent Mercy, and I'm a solo practitioner. I don't have a group, and I work with residents at the hospital. I do cover 2 smaller community hospitals, and 90% is spine surgery. The rest basic general orthopedics, and been doing kyphoplasties for 21 years.
Wow. So, is that a large part of your practice? You're doing a lot of them?
I do probably 200 to 250 a year, depending on the
That is a lot.
times. Yep.
Are there other physicians who do these at your institution?
Yeah, it's a combination, as you had stated, of neurosurgeons, orthopedic surgeons, pain management, interventional radiologist. The training in the beginning, as you kind of remember, they trained mostly for kyphoplasty, orthopedic surgeons and neurosurgeons, thinking this was a reduction of fractures. So therefore it was, specifically a surgeon-based practice. But interventional radiologists were the smart ones and did the vertebroplasties, learned the technique. And then of course the orthopedists kind of expanded on it just to try to up it one and, try to get more of a reduction.
Yeah, that's actually how I started doing them by working with spine surgeons who would have us do them for prevention of proximal junctional kyphosis after fusion. And that's actually how I learned was, working with them and then just kind of expanded my practice from there. So your institution, how do these patients, with vertebral compression fractures, how do they get triaged? How do they end up, getting you involved?
So my practice has changed remarkably, as we all have during the COVID time, but the majority of my referrals come from inpatient referrals, patients who've had pain symptoms, go to the emergency room, get triaged, either admitted or sent to the office. Some are sent primarily by the family practice doc based on their continued pain over time. And that's probably the majority of the practice that I see. Over the last 2 years, as we all have, those patients are sent outpatient and, come to the office. And this period of time, it's probably presenting more 6 to 8 weeks after their injury, whereas previously I really saw those people within the first week or two.
Yeah, that's interesting. I'm in a job, I work in Louisiana, and I've been here for about a year. And before I moved here, I moved like in the middle of the first wave of the pandemic. And before that, I was actually, seeing a lot of these as inpatients, and we would treat some of them while they were still there. We had basically a system we worked out with the ER. They would get them admitted for the night and we would treat them the next day. And now, the majority of ours are outpatient as well. But yeah, that's really interesting. We're also seeing a higher proportion of these later on than we had, a year or two before. That's interesting. I hadn't really thought about that.
I've noticed that I don't get the reductions I used to get. I don't get the lift or the height, and patients tend to have a few more recurrent fractures.
So that brings up an important point, about the timing of the fracture in terms of treatment. When you're working these patients up, ideally we want to get them in the acute phase, but how long do you consider too long after an injury to forgo treatment?
That's an interesting question, because really there is no too long of a treatment. As long as you have edema, MRI scan or stir image. If you have activity in a bone scan, or you see fracture cleft CT, I've treated patients almost a year and a half out that still have micromotion and fracture.
Yeah, we kind of do the same. We basically, unless we know for sure it's very acute, if it's, somebody comes in with trauma or, an acute injury, we'll be fine with a CT, but for pretty much everybody else, we're requiring an MRI. Is that the same for you?
If possible, yeah, absolutely. It seems like the cardiologists in my area have given everyone pacemakers, defibrillators, or now bladder stimulators. So we're kind of messed up on getting an MRI, but truly, MRI is the gold standard, yes.
How are you managing that when you can't get an MRI in terms of triage? Do you go by exam, bone scan?
Combination of both. Yeah, I think as an orthopedic surgeon, my first line of evaluation is a standing upright x-ray. Everyone says, really? Why standing? Well, I've seen a lot of fractures. Probably at least 1 out of 10 had CT, had imaging at the ER, didn't have a standing x-ray. I see them normally within a week from the ER, many times within 2-3 days. And you get a standing upright x-ray and they suddenly have a collapse. I've seen a complete plana.
No kidding.
Yeah, absolutely. It's incredible, the difference.
I've never even thought to order them as a standing film for these patients. That's useful information.
Yeah, commonly also, as example, spondylolisthesis is missed. You get an MRI, you get a plain x-ray, and you stand the patient up, they have a grade 1 slip. So same as with fractures.
So Tom, in terms of treating these patients, are you doing exclusively kyphoplasty, or do you also perform vertebroplasty or other forms of vertebral augmentation for compression fractures?
Probably 95% are vertebral augmentation. I do a vertebroplasty if I do a big degenerative spine scoliosis to offset, the proximal junctional kyphosis and my proximal screws. Yeah. If I see a older, real chronic type fracture, mild edema, I know I'm not going to get a reduction. So to me, a vertebroplasty is great for that. Or if they have one of those segmental fractures between a fixed level, that little bit of edema in the anterior edge, which I think is a common missed thing, not read by, some of the colleagues, I will put a vertebroplasty in there to stabilize it.
Okay. And you do that at the same time as a kyphoplasty for other levels, or you occasionally just bring that patient in and treat the vertebroplasty at that level?
The same time.
Okay. Yeah, I'm with you. It's interesting. And in my last job, I was at least 90% kyphoplasty. I would occasionally, as you said, for like an older looking fracture. And then for me, sometimes vertebraplana, where I'm nervous about inflating a balloon there, I'll sometimes just go with cement. But, I joined a new practice here, and it was a group that did exclusively vertebroplasty. There was a guy, didn't really believe in using the balloons. And so that was a battle I had in my first year here. I still am a believer. One of the things we brought you on to talk about today was doing these from Unipedicular or Bipedicular access. I mean, for me, that wasn't really an option until like 5 years ago. But it's interesting to note that, I was talking about the guys in my group, they actually do all of their vertebroplasties from Unipedicular access, but without curved needles. They just, rotate the eyes such that they can get the needle directly in the middle. And that's how they do all of them. For you, roughly what proportion of compression fractures are you treating from Unipedicular access compared to Bipedicular?
It's probably 20%. A lot of it is random luck. I'm planning Bipedicular and my needle catheter balloon is in the midpoint. And it's like, hey, this is great. Reduce the fracture, got my void. I'm good with it. So it's probably 20%. Those that have multi-level fractures, such as in the myeloma patients, the primary steroid-induced osteoporosis from secondary, those definitely multi-levels. Just for cost savings, I'll go Unipedicular.
Okay. Do you ever use any of the curved needles to get across?
I don't. I bend my balloon catheter. Actually, if you make a little curve in the catheter, you get to your midpoint.
I've never tried that.
Yeah. It actually works pretty good.
Do you have to put a cannula or anything out past there to get the balloon? Or, I guess for soft vertebral bodies, you may not have to.
Right. Usually for those that have clefts, they have the, what's termed Cummel's disease, the osteonecrosis.
Yeah.
Those are great. It curves right along the front and really inflates it excellent.
So, you said cost savings. Are there any other benefits to doing it from Unipedicular access rather than Bipedicular?
That has been debated, the studies, and I actually kind of looked up a lot of the stuff to see. Theoretically, according to all the meta-analysis, not really. You decrease the cement fill, you decrease the usage of the cement, you can get a volume less normally with Unipedicular, but it's a cost and the time, and then less radiation possibly.
Yeah, and, I guess theoretically just going from one side, slightly less invasive. It's still the same procedure pretty much. I used to use the curved balloons from Unipedicular access and get across, and and the curved cannulas, and I did have good results from that. I found that there was a learning curve with that, in terms of getting out there and covering as much of the vertebral body as I could. But the argument that was made to me for why you should stick with Bipedicular access was just, you get superior cement fill. I don't know. What's your take on that?
Well, as an orthopedic surgeon in training of fractures, that's how I base it.
Yeah.
Fracture principles based on the AO principles is, you've got to have fracture fixation anatomically. Then you have to make sure that you do it as a soft tissue sparing approach, which vertebroplasty and vertebral augmentation is. You want to mobilize the patient safely, but you also want that stability. The question is absolute stability or relative stability. And that goes back to, again, difference between colleagues and orthopedic and neurosurgeons. We believe in the bone. Be the bone. We own the bone. So
yeah,
fracture healing is different. You have whether it's the spine, long bone fracture, you still heal through the same 4 phases, which is hematoma in the first week. Then you have your fibrocartilage. So your cartilage model kind of forming the fracture, stabilizing it. Then by the 3rd week, you start to have callus formation into cartilage, and then finally long-term remodeling. The issue is the flat bones tend to heal more by intramembranous ossification versus what's called endochondral. So like you, I've actually been doing a little bit more vertebroplasty. My practice changed. I tend to not be filling as much because I'm wondering if we're making them too stiff, and too rigid.
When you're doing them, then, what's your endpoint when you're treating these, in terms of cement fill? Do you use a volume or do you use, kind of imaging findings? That's something, endpoint has been a challenge for me since I started doing these. I will go to great lengths to not reflux cement. I'm so nervous about getting into the epidural space or something like that. And to this day, I haven't done that. But, I see some people out there, you see cases shared on Twitter where people are really aggressive and you see these vertebral bodies that are entirely black. And I haven't been able to pull the trigger on going to that length.
That has been the trend, but I think it's falling away. In the beginning, the fill was important. We used to fill 3 cc balloon. You only fill 3 cc's. Early studies in the early 2000s showed that if we don't get the bone interdigitating between the compacted bone, you lose your endplate. So you collapse a little bit, lose your reduction or your height. The trend then was to go to a fuller fill, bigger balloons, and maximize the fill. In terms of orthopedics, we always say it's about the reduction. So force equals pressure times area. The more force with the balloon, including the second generation balloons, over a larger surface area with more force got your reduction. But that also compacted the bone so much that we ended up having a very stiff vertebragrams, I call it, where yes, it's this big black cement-filled vertebrae. And we know that that puts some stress on the adjacent end plates. So I was always filling a little bit more, trying to make sure I filled the clefts and the crevices without overfilling. But it's tough to do because it's all patient variables. So I've actually gone to a little bit less, trying to get a not as expanded balloon, get my reduction, but don't overfill.
I do like to see it, enter that cleft if it's a, kind of horizontal fracture plane, if I can get it. But Tom, how do you gauge your reduction?
By X-ray, and I do all my reductions on a Jackson table. As a surgeon, I do them in the operating room. It's just easier for me.
Yeah. With general anesthesia?
Most of the time, yeah. I probably do 90% general, 10% conscious sedation. Because again, it's about the reduction. Patients get fidgety, they're not moving around if I can do it. And I think I can do a better job, especially if I'm doing Unipedicular, not irritating the soft tissues as much.
Yeah.
So that's how I do it. Really get them lordotic, trying to create that reduction moment, and then expand my balloon and see what happens.
That's interesting. So you try to, how do you get them more lordotic?
The Jackson table is what's called a four-poster. They have a chest pad that sits right on the chest, and they sit on the iliac crest and the pelvis. And then the whole entire thoracolumbar and lumbar spine is free. So they're very lordotic, extension-based. And it's amazing the reduction you get just from that.
Really?
Yes.
Okay. That's new to me, Tom. Okay.
It's harder to do when the patient's under a conscious sedation because you're trying to force the patient up, extend the patient, and they're hurting. So to me, that's one of the reasons, even with my conscious sedation, our goal is, as example, you give them some sedation, you give them a little Diprovan, little fentanyl, and if we're doing a conscious sedation, they're always up and sitting in a bed, right? And as you lower the stretcher back extending, if they don't have pain, then we can get them flat and lay them on the table. So they have to be able to completely extend flat from that sitting posture in order to do a conscious sedation.
I also think about how I would want to have this done. I frankly, when I'm doing this, I use a mallet, and that is a really jarring thing for a patient who's not entirely out, is feeling that mallet. I mean, it's not necessarily the pain, but I mean, feeling and hearing that mallet for a patient who's not like completely out. If they do remember something, to me, it seems like they remember that. And I have really, I started doing these with conscious sedation, and I have really gradually gone farther toward, general anesthesia in the vast majority when I can.
I agree. That's, patients hate that sound of the mallet. They hate that banging on the back, that pressure feeling. And I tell the patient, I'm poking around your nerves and spinal cord. I don't want you moving, and I wouldn't want it that way. And most of them agree. Oh, absolutely. I want to be knocked out completely.
And I mean, Tom, if you're doing my kyphoplasty in the future, I'm going to demand general anesthesia. And so that's kind of what I tell most of these patients. If I'm getting one, I'm going to want anesthesia. And it's not always, and it's not always an option, but when I can, that's what I'm doing.
Yeah, completely agree. And same here. I tell them I would have it done, be back working the next day.
Yeah. And that's one of the great things about this procedure. Generally, you can have them doing the majority of their activities within a couple of days or so if you get a good clinical result. Tom, does your approach to doing these from a technical standpoint change, the higher you go up in the vertebral column?
It all does, but it's based on anatomy. I tell the patient, and when I teach the residents, they always have the typical training, extrapedicular approach, parapedicular approach up above T9 or 10. And you get up to T2, T3, 3-4, they're huge pedicles, long, wide, half the body. So it's really a transpedicular approach. It's just a very small body, and you've got to be careful. So every patient is dependent on the fracture pattern. I really look at it, gauge my angle. Can I do it as Unipedicular? Or is this truly one that needs a reduction because it's at that thoracolumbar junction where you really want to get that sagittal alignment?
Do you ever, because you're in the operating room, do something kind of a hybrid approach where you make a larger incision and actually visualize the vertebral body?
No.
Okay.
No. Unless I'm doing an open decompression. There are those patients that have the fracture. They're on top of a stenotic segment, say a spondylolisthesis at L4 or 5, and they need a reduction. So those I will do kind of an open hybrid.
Tom, can you walk me through basically your follow-up for these patients? How do you assess your outcome and when you see them again and when you have circumstances where there's more to do?
Yep. Standard lecture to the patient pre-op is, we fix the fracture. You should be 50 to 70% better right away. Your sharp transitional mechanical pain, that pain getting up, getting down, moving, should be gone. I see them back at 2 weeks. I tell them to be careful bending and lifting, not to lift more than 10 pounds, keep weights close. And when I see them back, first thing I ask them is, how's your pain? Not a scale, but getting up and down. I make them stand up and show me their pain, point to it, where's it at? And I ask them what their pain level is. If they're 75, 80% better, I'm not too worried about adjacent level fracture. If they're like, well, yeah, it still hurts here, it's 60, 40% better, they have an adjacent level fracture. So I then get standing upright x-ray right there in the office, and almost always you see that adjacent level fracture.
Man, no kidding.
Yep.
And so where do you go from there?
Well, then I talk to them about, is this something we should fix? Is it because we made it too stiff? Did they have a fracture? Say they only had a CT scan that didn't show the fracture.
Yeah.
Or are they willing to go through, quote, medical augmentation, calcium, vitamin D, brace possibly, give them a couple weeks, see them back in 2 weeks, get another upright x-ray. If they show a fracture, then we talk about surgery. But I give them the option of going back and doing an adjacent segmentation.
And so when you say surgery, are you talking about a fusion or are you talking about doing another vertebral augmentation?
Another augmentation.
Yeah.
Or possibly a vertebroplasty, especially if that inferior end plate is starting to break. I don't want to make it stiff, because I have seen same horribly osteoporotic patient who, as a side, I always try to get a DEXA scan before their procedure so I know what I'm dealing with. But if they have terrible primary osteoporosis, I'll then recommend like a vertebroplasty instead, because I think it's less stiff.
Okay. Tom, what else am I missing that's, important to talk about regarding this procedure?
Well, one of the things that I have been working with lately has been the Kyphon assist. Again, help in reduction. I think as much information as we have, as much literature is out there, we really don't know how much cement do we really need and in what patient. We know if you get kind of a blocky, chopped, squared off, dense bone, you tend to have an adjacent increasing fracture. If you kind of get that spongy, kind of described, flow in vertebroplasty pattern, they tend not to be as stiff and sore. And then I think it's a matter of, what do we do? So for me, the reduction has been better with the Kyphon assist. And the good point is, I can get that flow into the other parts of the vertebrae as a vertebroplasty by rotating my Kyphon assist, or scoop cannula is how I call it, to get the other areas. So I can control the flow into the vertebrae.
Tom, for the listeners, what is the Kyphon assist?
So Kyphon assist is basically a scooped cutout cannula, same as your size 2 or size 3 cannula. And it acts as a ramp, so the balloon gets directed to a certain area. It helps increase height reduction, and it controls your flow of the cement.
Do you still do a single inflation when you're using the Kyphon assist, or will you ever, direct it to, the top or the middle or bottom, inflate more than once?
Both. If I'm too lateral with my needle or catheter, I can use the Kyphon assist or scoop to push it more medial. If I'm too low, I can push it high. And sometimes I will bail out and go to the Kyphon assist because it makes my fill better. So each of those are great options and great, tools that I think people need to know about in doing vertebral augmentation.
I'll ask my rep this week. Well, Tom, thank you. We really appreciate having you on here and for sharing your expertise and perspective. This has been extremely valuable for me to really hear how you look at this as a spine surgeon, as a bone specialist, which frankly is a bit different from how I do. And, I think we can really all get a lot from this. So again, thank you for sharing your time with us.
My pleasure. Thank you for having us.